طيب بسم الله الرحمن الرحيم. ودي يعني المحاضرة الثانية في سلسلة المحاضرات. بداية قبال المحاضرة يعني أشكر النواب إنه الليلة يعني الالتزام يعني أحسن كثير من المرة اللي فاتت. الحضور يعني بداية المحاضرة أحسن كثير، وإن شاء الله إحنا نتمنى إنه الناس تكون كلها حاضرة لقدام. زي ما قلنا دي سلسلة محاضرات حتواصل لقدام. يعني معظم الناس الكواليفايد هسه اليومين دول حيكونوا برا السودان. الحين حنستغل الحاجة دي عشان نوفر مثلا هاي كواليتي بتاع محاضرات، وفي حاجات كثيرة حنحاول نغيرها ذاته للكواليتي ذاتها بتاعت المحاضرات، انها تكون مفيده. لكن عشان تكون مفيده احسن حاجه اهم شيء الناس تكون موجوده وحاضره وملتزمه بالمواعيد، عشان الناس تجي تحكم مثلا حنقول الساعه 8 بتوقيت السودان، الساعه 8 بتوقيت السودان. الليله ضيفنا في المحاضره او المقدم المحاضره دكتور بشرى الحسين. دكتور بشرى الحسين he's an attending psychiatrist at Victoria Hospital في London Health Science Center in Ontario في كندا. Additionally, he is an assistant professor at the school kick. كده نطقها صح ولا
شولك
غلط؟
شولك
Chulik School of Medicine and Dentistry دي برضه في كندا. He's a primary lead for mood disorders and anxiety disorders at the University of Western, and his work involves inpatient and consultational agent psychiatry. He's passionate about teaching and research and serves as a reviewer for psychiatry journals such as Frontiers in Psychiatry and BMG. Dr. Al-Hussein is a member of the Canadian Psychiatry Association and the Ontario Medical Association. And without further ado انا هتخلي الدكتور هنا دكتور بشرى يتفضل. بس افتكر الناس الموجوده اي زول حيكون حاضر معلش اعملوا ساينت للميكروفون. السيشن again is going to be interactive، يعني encouraging people to talk. حتى ما من ما من هنا ما من اسمه شنو chat، يعني just raise your hand ويعني تفضلوا في الconversation. We want this to be as يعني as interactive as possible. تفضل دكتور بشرى.
طيب، بسم الله الرحمن الرحيم. السلام عليكم جميعا. شكرا دكتور ياسر، دكتور عبد الغني، دكتور عبد العظيم، وكل الناس القايمين على المجهود الجبار ده يعني، وإن شاء الله نقدم حاجة تكون مفيدة. حقيقة عايز just to add to الحاجة اللي قالها قبل شوية دكتور عبد الغني ودكتور ياسر، إنه it's always better إنها تكون interactive session. It's a safe learning environment, no judgment، وكلنا بنتعلم من بعض يعني. فالزول عادة will retain more information when it's in a discussion rather than just passive listening and lecturing style. طيب، التوبيك بتاعنا شوية very complicated, extensive amount of information. عشان كده حيكون صعب إنه to cover it in 1, 2 or 3 or even more lectures. يعني it needs a lot of time devoted for psychopharmacology. عشان كده this is just an introduction to psychopharmacology. I will try to cover the basics and يعني لما نغطي الوقت بتاعنا then we'll stop. However, I'm more than happy to give more lectures in the same subject إذا كان في حوجة يعني. طيب، psychopharmacology our objectives today هتكون first understanding the pharmacology basics, reviewing the essential concepts in pharmacodynamics and pharmacokinetics relevant to psychiatric medications, and we'll quickly go over main classes of medications that we use in psychiatry, and then discuss key aspects that include indications, mechanism of actions, and common side effects. I don't know if we would have time for clinical guidelines to discuss that. I don't think so, but that would be one of the maybe objectives in the futures, and then discuss some of the challenges that we see with medications in certain patient population. طيب, when we say psychopharmacology, what do we mean by that? psychopharmacology, and in a very brief way, is the effect of medications on mental state. ده باختصار شديد. لو جيت definition يعني APA definition, for example, it's psychopharmacology, the study of substances that influence mental states. Such agents induce changes in mood, sensation, thinking, behavior, and may be derived from ممكن يكونوا plants, ممكن يكونوا natural sources, or chemically synthesized. فعشان نختصر ده كله, the effect of drugs on the mental state. Why we're studying this? Because it's an essential field in psychiatry, bridging the gap between pharmacology and our clinical practice. And it provides a crucial foundation for understanding how medications can be used to effectively treat mental health disorders. الفوكس بتاعنا حيكون على السايكوفارماكولوجي and examining how drugs interact with the brain at neurochemical level. That as a quick introduction. So in order to talk, or whenever we talk about psychopharmacology, we have to discuss two main parts. The first one is pharmacokinetics or pharmacokinetics, and the second part is pharmacodynamics. What it comes to your mind when we talk about pharmacokinetics? Kinetics, you see this word in different, it's a very common word in psychiatry. You have dyskinesia, bradykinesia, hyperkinesia, akinesis. So it's related to movement, right? So pharmacokinetics, we're talking about the movement, is the study of how drugs move through the body. And in order to study, go through different phases that include ADME, absorption, distribution, metabolism, and elimination. So absorption refers to how drugs enter the bloodstream from the site of administration, whether that's oral, intramuscular, IV, through the skin. So all of these different resources. The absorption also include the substances or chemical. It depends on the chemical properties of the drug and the presence of food in the gastrointestinal tract. As we know, some drugs might be better absorbed when taken on an empty stomach, while others might need food or to be used with food. And I don't know if you have, like, most commonly drugs need or absorbed very well or much better when administered on an empty stomach. However, we have some medications that we need food, or to make sure that the patient is eating something before taking the medication. And I don't know if one of the trainees can give us an example of these drugs, or how can food in general affect absorption of medications. Anything in mind?
Absorption, lorazepam need food.
Exactly.
Best, yes.
Yeah.
Diazepam, I think empty stomach is better absorption.
Yes. So lorazepam is one of the second generation antipsychotics that actually needs food to be well absorbed. And the relation between food and medication are really important. Some of, for example, grapefruit is an enzyme inducer, can cause an increase in the level of some medications. But there are other substances as well that can affect or even can increase the possibility of side effects with certain medications. The example that I can remember now is the MAO inhibitors, although they're not commonly used now as an antidepressant, but we need to avoid certain food with these medications to avoid like aged food. Cheese will be the best example to prevent adverse effects. Absorption is one of the basics to understand well the pharmacokinetics. The second step is distribution. And distribution describes how drugs spread throughout the body after entering the bloodstream. So the distribution of drugs depends on its ability to reach or cross cell membranes to reach their target organs. And for example, here we're talking because most of our medications, their final effect on the brain, and knowing or understanding whether this medication can cross the blood-brain barrier will make a huge understanding of how they work. That's just an example. Other factors like blood flow, tissue permeability, and protein binding can also affect distribution. That's why people with hypoalbuminemia, decreased blood flow for any reason, the drug level and the distribution of the drug might be affected. And then number 3 is metabolism, which is the process by which drugs are degraded or broken down, primarily by enzymes in the liver. Most of these medication will undergo first-class liver metabolism, which are often less active or more easily excreted when they're broken down into smaller substances. Factors influencing metabolism include, again, age, genetics, or liver function, or the presence of other drugs or substances in the body. That's why polypharmacy, one of the challenges usually. And then the last step or the last phase with the pharmacokinetic is the elimination or excretion, which refers to how drugs and their metabolites are removed from the body. And that's mainly through kidneys. And that's why, again, with chronic kidney disease, for example, we might need to use lower doses to avoid accumulation of a drug and avoid toxicity. However, not all drugs eliminated through the kidneys. Some of them, they might be eliminated through the lungs, with the GI tract, with the bile, or through the skin. Again, because it's highly important, the connection between liver and drug metabolism, there are factors affecting drug metabolism. Liver function is number 1. So impaired liver function can slow drug metabolism and potentially leading to toxicity. This can be due to various conditions like cirrhosis, hepatitis, or even age-related decline. And that's why we notice that in elderly, for example, we have to use lower dose because of the declining liver function to avoid accumulation and further toxicity. But that doesn't only include older age group. In younger group with a liver impairment, we have to be careful about the drug, and we have to know whether it uses like first pass metabolism through the liver. And just to make it interactive, as we said earlier, let's say that you're the on-call resident in the emergency department. You have this patient who is 20-something years old, seen by emergency physician, diagnosed with alcohol intoxication, referred to you in psychiatry to be under the addiction team. They cleared him medically. The only issue now is alcohol intoxication based on the long history of chronic alcohol use. They ordered the blood test, CBC, liver function, referred the patient. What are your next steps here? In relation to what are we discussing now? Liver impairment and medication use.
السلام عليكم. How are you?
Salam.
كيف يا دكتور؟ For me, I expect إنه حيكون liver functions impaired because of long use of alcohol. For detoxification, benzodiazepines طبعا will be the first choice, chlorodiazepine oxide and diazepam, but both of them are contraindicated when the liver is impaired. So I will go with lorazepam or oxazepam or temazepam.
Yeah, excellent. So that's highlight actually the importance of knowing about liver function and medication, being aware of what medication are metabolized outside of the liver, what medications go through first pass hepatic metabolism. And again, in this case, liver function will indicate chronic alcohol use. What do you expect to see with the liver function? معلش طلعنا شوية من الموضوع لكن what do you expect to see? What would indicate that this is due to alcohol use rather than a primary cirrhosis or hepatitis?
السلام عليكم.
عليكم السلام.
I expect chronic alcohol use may do enzyme inhibitor. This factor for enzyme to be slow.
Okay, so what's about ALT and AST? What do you expect?
Maybe this transaminases be high level of ALT and AST.
Okay, and there is any difference between AST and ALT? Would be like any of these like higher than the other that could indicate more?
Yeah, GGT and AST will be higher.
Yeah. So
in chronic alcohol use, I think.
Right. So both of them would probably be high, but usually AST is higher, maybe double the amount of ALT. And in terms of CBC, when you do CBC, what do you expect with someone with chronic alcohol use?
Okay, my name is Yusuf Fadlallah. I think most patients with alcoholic will be malnourished, so we will find normocytic, normochromic anemia.
Okay, that's if they have a comorbid chronic condition that causes chronic anemia, which is usually present with normocytic, normochromic anemia. But what about alcohol in particular and the size of MCV? So you're in the right direction. You're talking about the MCV. But is it normochromic or normocytic, I mean? Microcytic, macrocytic?
My name is Mujahid. I am R4.
Okay, if the patient was comorbid with vitamin B12 deficiency or folic acid deficiency, he will have an increased size of MCV and MCH that will cause macrocytic hypochromic anemia. So he will have definitely increased MCV and MCH.
Okay. Yeah, I see also in the chat as well. Most people said that it's macrocytosis, and that's what we see with alcohol. Like it's hard to find only alcohol, because usually they might be malnourished, and then you might find other anemia, type of anemias due to malnutrition. But let's say, just for the sake of learning, alcohol come with macrocytosis. But again, you have to rule out like vitamin B12 deficiency, which is another cause for macrocytosis, or even bigger cell size compared to alcohol. It might be megaloblastic with B12 and folate deficiency, but that's a common. There are other causes like chronic liver disease, which alcohol part of them, but chronic liver disease for other causes. Hypothyroidism, another reason for macrocytosis. Like Montaz. Now we're going to talk, I don't know if I missed the slide. Okay, so we talked about liver function, we talked about age. We have genetic factors as well that affect drug metabolism. If there is anyone who wants to talk about the intersection between genetic factors and drug metabolism, CYP enzymes. So CYP enzymes, which are responsible for drug metabolism, can significantly affect how a patient or an individual can process certain medications. These variations known as polymorphism, if there is an abnormality, and that's why maybe you heard about, we have certain type of populations based on their genetic background. They're fast metabolizers or slow metabolizers. So if they're fast metabolizers, then we need to use higher doses of medications to get the desired effects. While if they're slower metabolizers, we need to avoid giving them higher doses of medication to avoid accumulation and toxicity. So that's another part that plays an important role on drug metabolism. Type. Now the second part, which is pharmacodynamics. Pharmacodynamics, we're talking about action, mechanism of action. And to understand that well, we have to go through receptor binding, dose response curve, and the therapeutic index. Receptor bindings, طبعا كل الدراجز especially antipsychotics, for example. كل drugs in general, not the antipsychotics. We'll talk about that when we talk about the antipsychotics and their effect on dopamine receptors. But drugs in general, they interact with specific receptors, and بيعملوا حاجة من اثنين. Either they act as agonist or antagonist. Agonist معناتها في activation, they activate receptors. Antagonist, they block the receptors. عشان نوضح المسألة دي أكثر، الانتيسايكوتكس مثلا they're blocking dopamine. They're inactivating dopamine by blocking its action. So they're dopamine antagonist. Okay. While antidepressant agonist لأنه they increase the serotonin level. In general, agonist activate receptors, antagonist block receptor activation. ده بالنسبة للريسبتور بايندينج. الحاجة الثانية اللي هي الدوز ريسبونس كيرف. Dose response curve depict or illustrate العلاقة بين drug dose and physiological response. The relationship between the drug dose and physiologic response, this is defined as or define the dose response curve. These curves يمكن عارفين إنه كل psychiatric medication differ from the medications that are used mostly in other specialties. يعني for any infection, amoxicillin 500 TID, that will be used the same for otitis media in an 18-year-old or 60 years old. Psychiatry عندنا الموضوع شوية مختلف. We start low, go slow, because we have to bear in mind the dose response curve. And these curves typically show a sigmoid shape, وده معناته إنه indicating إنه as the dose increase, the response initially rises slowly, then rapidly قبل ما يصل مرحلة كده بعد كده receptors تكون saturated ويكون in a plateau phase. We will not get any further response after increasing the dose further. In fact, might just get more side effects. And then we have the therapeutic index, and which is defined as the ratio between the effective dose and the toxic dose, the relationship between this. This ratio, the therapeutic index, indicates the safety of a drug, with larger therapeutic index suggesting a wider range or a wider margin between the dose that produces the therapeutic effects and the dose that result in toxicity. The example for that, give me an example for a wide therapeutic index and a narrow therapeutic index. Anyone?
My name is Ahmed Sanhouri. For me, narrow therapeutic index is well known for lithium.
Mm-hmm.
Wide, I'm not sure, but I guess most of SSRIs, antidepressants, have wide therapeutic index. But narrow therapeutic index is for lithium.
Right.
Wide, I'm sure, but I think SSRIs, most of them.
So when you're right about the narrow therapeutic index. Lithium would be the perfect example. It's very narrow because we have to maintain lithium between, in most guidelines, between 0.6 to 1.2. Higher than that, even some people might go into toxicity when they're receiving a therapeutic dose, and that's why it's essential, although we're using a treatment dose, to check the lithium level. And يعني نخلي في in our consideration that there are some drugs that might increase the lithium level, so we don't add lithium to these patients, and some other factors might lead to lower lithium level. Medications, ACE inhibitors, NSAIDs, non-steroidal anti-inflammatory drugs might increase lithium level, and situations where you can have falsely lower lithium level. It's not falsely, in fact, it's accurate. But although the patient on the same dose, but you check the blood level and you see it low, we see that in pregnancy, especially in the second and third trimester, because of the increased blood volume. The other example would be antidepressant, TCA, tricyclic antidepressant. They have narrow therapeutic window. That's why they're highly toxic, that can cause arrhythmias, seizures in cases of toxicity. While most of the over-the-counter medications طبعا في حاجة مهمة المفروض احنا نعرفها لما نقول انه wide range, yes, safety increased, لكن it doesn't mean انه the drug is not lethal or toxic. Well, perfect example for this is acetaminophen, اللي هو الباراسيتامول. It's over-the-counter medication, has wide range therapeutic index, but it's very toxic when taken in overdose. Like, just to reach that, you need a big amount of medication. So, or a big dose, higher dose of medication. So it's an important step to know about the therapeutic index and the range of toxicity for certain medications in psychiatry. Then we have major drug classes in psychiatry. The top three are the main medication that we use, اللي هم antidepressants, antipsychotics, mood stabilizers, and then we have stimulants, hypnotics, anxiolytics, medication to treat substance misuse, and so forth. But our big three هم antidepressants and mood stabilizers and the antipsychotics. طيب هنبتدي بالانتيسايكوتكس. Since يعني ال 1950s تقريبا they started to treat psychosis. أفتكر الكلوروبرومازين was the first antipsychotic. He treat psychosis in general, whether acute or chronic, like schizophrenia, لكن used في حاجات ثانية زي bipolar disorder, especially when we have psychotic features, for agitation sometimes. أحيانا برضو we can use it as augmentation with antidepressants, augmentation for medication to treat OCD, and so forth. Antipsychotics, we have two classes, first generation antipsychotics. Or I need some examples of the first generation antipsychotics, or if you're aware of any sub-classification of first generation antipsychotics. Anyone?
البرودول كلاس البرودول هما الفيريشن اسمهم النيوروليبتكس أو الكونفنشنال انتيسايكوتيك.
تمام. Thank you. Any other medication belong to this class?
By mosaic, high potency.
Okay. These are the first generation antipsychotics as well. So as you mentioned, first generation, we have first generation and second generation. First generation also called neuroleptics, conventional or typical antipsychotics. While الجروب الثاني اللي هو second generation antipsychotics or atypical antipsychotics. First generation primarily function by blocking dopamine, post-synaptic dopamine at D2 receptors في الcortical and striatal regions. في high correlation between D2 receptors in particular binding والclinical potency بتاعت الفيرست جنريشن. عشان كده مقسمين ل 2 subclasses اللي هو high and low potency first generation antipsychotics. الهاي potency زي ما شايفين list of medication but one of the still commonly used medications زي haloperidol, of course, especially in acute setting for agitation. Trifluoperazine to some extent, fluphenazine to some extent, but all of these medications are first generation antipsychotic, and they belong to high potency. كل first generation antipsychotics, they have no specific localization. When you read about research and studies, the mechanism of action, the first generation, they have like vague localization. بالنسبة للدوبامين binding through the central nervous system. والحاجة دي consistent مع الريسك بتاع why they have more likely propensity to cause EPS, extrapyramidal side effects. غير إنه they block D2 receptors, أو they work as D2 antagonists. Each first generation بعد كده عنده its distinct and individual side effects depending على إنه بيشتغل شنو تاني على غير ال D2 blockade. هل هو أنتي مسكرينيك، أنتي هيستامينيك، أنتي كولينيرجيك، ده بيحدد لنا ال other side effects. الهاي potency just دي حاجة بس بتساعد على إنه to memorize ال group of medication ده. رغم إنه زي ما قلت يعني they're not commonly used now apart من الهالدول تقريبا. الهاي potency النمبرز بتاع المليجرامز usually هم high لكن النمبرز low، they're 1 to 10s of milligrams, while a low potency they're in 100 milligrams زي الكلوربرومازين. هنيجي نتكلم برضه عن كده. They exhibit a high potency, low histaminic and muscarinic receptor activity, and they have less anticholinergic activity. هم low. طبعا لما نقول low ما معناته انه ما بيعملوا sedation او ما بيعملوا weight gain او ما بيعملوا urine retention. No, they do. لكن less likely compared to low potency. So they're less sedative, less weight gain as a side effect compared to low potency first generation antipsychotic, but higher EPS than lower potency. إن شاء الله ما أكون confusing you هنا في الحتة دي. بيعملوا EPS أكتر لكن less sedation, less weight gain than low potency. A low potency, less EPS, but more sedation, more weight gain, more anticholinergic side effects اللي هو blurred vision, urinary retention, and so forth, especially orthostatic hypotension, especially with the elderly. Medication like chlorpromazine should be used very carefully or avoided. فدي high potency first generation. Low potency عندنا main two, chlorpromazine and thioridazine. Thioridazine, I don't believe that it's used now. And a lot of side effects, including some eye complications, pigmentary retinopathy, retinitis pigmentosa has been reported with this medication as well, in addition to its antihistaminic, potent antihistaminic action, anticholinergic action, and antimuscarinic, the effect on muscarinic receptors, similar to chlorpromazine, but an eye complication actor مع thioridazine. زي ما قلنا dosed in hundreds of high histaminic, muscarinic activity with a corresponding increase of sedation and anticholinergic actions, but less EPS compared to the high potency. Okay. Absorption and bioavailability. Oral absorption of first generation may be inconsistent, and several of these agents زي ما قلنا بيمشوا through the liver, hepatic metabolism, resulting in low or variable oral bioavailability. عشان كده احنا in general in psychiatry, yes, you have a dose range, but your judgment should be relying on not the dose in particular, but on the clinical response. A daily assessment, عشان كده it's really important rather than what dose of medication you're using. First generations are lipophilic, highly protein and tissue bound as a class with a large volumes of distribution. عشان كده other factors like liver abnormalities, as we said, hypoalbuminemia might affect the bioavailability of these medications. أكثر واحد absorbed من first generation antipsychotics هو loxapine and perfenazine. At time عشان to reach a peak concentration from 1 to 3 hours. The oral administration. Other drugs are less predictably absorbed, زي الهالدول مثلا, which is commonly used. It takes all the way anywhere from 2 hours up to 6 hours عشان to reach a peak concentration. عشان كده sometimes we use طبعا الهالوبيريدول لأنه available as intramuscular injection, especially in agitated patients in the emergency. And sometimes if you're relying only on the haldol for agitation by itself might be not enough, given especially when you know انت عشان تصل al peak concentration you need at least from 2 hours, and it might take up to 6 hours. عشان كده أحيانا we may need to add something else to help sedating the patients. There is a كان ما في olanzapine IM مثلا. That's why we use diphenhydramine, for example, sometimes, or a benzodiazepine. Loxapine شوية كده it's a little bit weird. Oral absorption بتاعه زي ما قلنا واحد من أسرع الانتيسايكوتيك to reach peak concentration من 1 to 3 hours. Intramuscular requires 5 hours to be fully absorbed. more than twice a time اللي هو needed oral medication. So it's faster and higher concentration can be reached with the oral intake. في منه aerosol form من loxapine, which can reach the peak within 2 minutes, maximum 10 minutes. And that will result in much lower agitation in a very short time. Okay. طيب دي هنا in general هي this table, by the way, from up to date, and this is about the first generation antipsychotics, an initial dose. أنا عندي شوية كده ما واضحة السلايد كاملة. I don't know if you can see the whole slide or not. ياسر؟
ما خالص.
ما واضحة مش كده؟
خالص لا.
I think إنه لأنه التيبل a big table that include all the first generation antipsychotic. In general هنا بتكلم عن الدوز الانيشال دوز أفتكر the first one هو الكلوربرومازين. عشان هنا بنشوف الرينج مثلا في الانيشال دوز all the way from 25 up to 200. usual dose from 800 to 600 or 800. half life بتاعه about 30 minutes 30 hours sorry. عشان كده we can give it يعني once a day. Most of these medications can be given once daily. However, medication like Haldol, sometimes we might need to give them on divided doses 2 or 3 times, especially in cases of acute agitation. Selected characteristic, it's very small. I can treat it like, and I think we talked about all of that. This is mainly the dose range for different medications. Haloperidol, I don't know, I can't see it, but the dose, the initial dose, it should be this one. The initial dose between 2 to 10 milligram. 2 milligram usually in the inpatient ward if we're starting it as an antipsychotic, sometimes for agitation if the patient is accepting oral as well. But 10 milligram might be usually in the emergency setting. But this is the range between 2 to 10. Usual dose range from 2 to 20 milligram, and the maximum dose is 30 milligram per day. Half-life long as well. It can be used once daily. However, it can be used in divided doses as well. It's available as oral, IM, or long-acting. Sometimes Haldol can be used as IV as well, but there is a clear risk of QT prolongation. تقريبا ده the most important drug from here, from this list. إن شاء الله دي تكون واضحة لأنه it's really important this slide. Is this clear, Yasser?
واضحة.
Okay. So ده هنا ال adverse effects of antipsychotics, first generation again. Just looking at the table, I don't know if anyone can talk about just the first impression. Look at the number of pluses or crosses. الحاجة الملاحظة هنا شنو بالنسبة للفيرست generation antipsychotics.
Most of extrapyramidal symptoms are caused by first generation antipsychotics.
Yeah. So that's very clear هنا إنه لو مسكنا الثلاثة الأوائل مثلا weight gain, glucose and hyperlipidemia, these are the main components بتاعت الميتابوليك syndrome اللي هي more common مع ال second generation antipsychotic. فهنلقى معظمهم هنا ديل hyperlipidemia مثلا كلهم one cross. Glucose مثلا chlorpromazine, which makes sense, اتكلمنا عنه، هو واحد من ال low potency first generation antipsychotic. فيه عنده more antihistamine, anticholinergic action, muscarinic activity، عشان كده more likely to cause sedation. وهيكون معها طبعا weight gain. لكن ال other medications مثلا كلها one plus. ده بالنسبة للجلوكوز. Weight gain 2 maybe thiothexine is only one, molindone one, loxapine one. لكن الهالدول والفلوفenazine, chlorpromazine, they have some degree of weight gain, but again less than when it's compared with the EPS side effects. من هنا akathisia, Parkinsonism, dystonia, tardive dyskinesia. خلينا ناخد ديل مع بعض. اللي هم ديل بتاعين ال APS. You can clearly see يعني تقريبا كل الميديكيشن دي there is very clear side effects of APS with all of the medications. Look at Haldol, for example, كلهم. الفلوفينازين كلهم. And thiothexine as well. 3 crosses all over the 4 parameters. طيب طالما بنتكلم عن ال first generation antipsychotics, let's say what is akathisia? خلينا نمسك واحدة one by one. What is akathisia?
Subjective feeling of restlessness.
That there is any objective part? Tamam. Subjective, yes. Any feeling of restlessness or a desire to move or inability to sit still. لكن في or معاه يعني ممكن معاه يكون في objective observation. انت ك
Moving legs.
نعم.
Moving legs.
Yeah. إنه
Moving around.
moving around, pacing, unable to sit still. يعني عشان كده mostly بالذات لما تكون severe بيكون it's a subjective expressed by the patient and objective seen by the healthcare provider. If there is any psychometric test to measure akathisia, يعني ممكن نعمل لها scoring بأي حاجة أو عشان نقدر to monitor the patient over the course of their stay مثلا نشوف في improvement في deterioration في أي حاجة نقدر نقيسها بها. The gold standard is Barnes.
Barnes akathisia scale.
Yes, thank you. So Barnes akathisia rating scale or Barnes. If you score from 0 all the way to 8, 0 معناتها ما في symptoms or sign to indicate akathisia. 8 severe akathisia. And medication. طيب how to treat that akathisia?
Anticholinergic drug.
First to stop the medication.
Beta
Decrease.
blocker.
إذا في إمكانية ممكن نقلل الدوز of the drugs. ممكن نديه بروبانول أو نديه كلونازيبام.
Can be changed from first generation to second generation. Benzodiazepine, beta blocker, mirtazapine.
Okay, tamam. Yeah, so it should be like a stepwise approach. فإذا كان في البداية هو ال main reason هو طبعا in this case يعني since we're talking about the first generation هو الميديكيشن أو الانتي-psychotic, فيبقى reasonable إنه to lower الميديكيشن and switch to a second generation or with a medication that is less likely to cause akathisia. That will be the best approach. طبعا في medication من ال second generation they're يعني برضو عندهم high association with akathisia زي
الاربيبرازول.
زي الاربيبرازول, pexiprazole as well. لكن نمشي لحاجة less likely إنها to cause akathisia من ال second generation other than these medications. ده one approach. أحيانا ممكن يكون البيشنت started على long acting Haldol مثلا, haloperidol long acting. So it might be risky is a patient يا دوب أخذ long acting haloperidol 4 or 5 days ago developed akathisia. ما عندنا المجال بتاع إنه إحنا نوقف الهالدول لأنه it's a long acting and it needs a period of washout. adding a second generation antipsychotic now at this time might increase the problem and increase akathisia. So we have to go for other medications to treat akathisia. We can use one of the options that you mentioned. Is there can be other EPS symptoms, dystonia, rigidity, in additional akathisia, maybe an anticholinergic like benzotropine might be the best option to go with. However, we have in certain situations where we have to be very careful. يعني إذا كان البيشنت elderly أو إذا كان young لكن عنده other comorbidity يعني let's say a male in his 40s, history of benign prostatic hypertrophy, then you might want to avoid that because of the anticholinergic side effects, urine retention, which will just complicate the situation. And then you go to the other options. You mentioned benzodiazepines. These are well-known treatment for that. There is recent evidence for B6, vitamin B6 as well, to treat akathisia. And there is good evidence for propranolol, as you mentioned, but we have to make sure that there is no other comorbidities, no orthostatic hypotension, no bronchial asthma, where we can go for mirtazapine, for example, which is one of the other options. A low-dose mirtazapine seems to be effective and very similar or equivalent to the effect of propranolol on a high dose. So mirtazapine might be something that you want to go for. However, again, it's the presentation of the patient. And if you're treating, and واحنا بنتكلم عن small dose or low dose of mirtazapine. However, if the patient عنده history of bipolar disorder, you might need to avoid using an antidepressant since it's an antidepressant, although it's a small dose. And there are some reports, it's not an evidence, about few case reports of mirtazapine causing or inducing akathisia. But when you go in depth to these studies, they either lack the psychometric test and there is no bars scale done, أو كان في other confounding factor. Many of them يعني كانوا بيكونوا على other antidepressant أو medication that could cause akathisia. الإيفيدنس, the best evidence is with mirtazapine, not against. In addition للحاجات التالية اللي ذكرتوها دي. طيب Parkinsonism, which is the second one here. Why antipsychotics in general, whether first or second generation, cause Parkinson-like features? What's the reason behind that?
blockage of D2 في negative striatum.
Yes. So we're kind of inducing Parkinsonism when we use dopamine blocker, which is the main mechanism behind Parkinson's disease. And then dystonia, we have acute dystonia, which can be just a group of muscle contraction, but it could be a lethal condition if it involved like the larynx or pharynx, might be lethal and need to be treated immediately. Tardive dyskinesia طبعا comes with akathisia مثلا, more common in drug naive, non-Caucasian male. Tardive dyskinesia, however, more in female with the chronic use. That's why with advanced age usually. So إذا شفنا هنا تاني كل الجروب ده هنا كده كله EPS وكلها much more common مع first generation antipsychotic. Now coming to prolactin elevation, what's the relation between prolactin elevation and antipsychotic?
blockage of D2 في tubular.
Okay, and that will lead to? ليه ده بزيد البرولاكتين؟
هيحصل لوس الانهيبيشن. هما الدوبامين بيعمل انهيبيشن بالبرولاكتين.
Exactly. So لأنه البرولاكتين is inhibited by dopamine, and لما يكون الدوبامين low, then we lose that inhibitory effect, and that will lead to prolactin elevation. And that's why it's usually important and crucial to have a baseline prolactin level in patients with first, especially in the first psychotic episode or drug naive patients. لأنه الprolactin can increase few hours after starting an antipsychotic. So if you miss that and do it even the next day, it might already be elevated, and then you miss. طبعا pathological causes for hyperprolactinemia other than pregnancy والphysiological والlactation والحاجات دي إنه ممكن يكون micro or macroadenoma. Macroadenoma has physical signs, يعني الناس بيجوا by temporal hymenopsia, gait disturbances, vomiting, headaches, يعني عندها manifestation or signs. لكن المicroadenoma, it might be very tiny, small tumor, even undetected by imaging studies. And you might be in this tricky situation where you don't know whether this your antipsychotic medication, which is expected, or there is an underlying physical condition like microadenoma. الفيرست جنريشن زي ما شايفين هنا معظمها ما عدا الكلوروبرومازين يعني to a lower extent. لكن other high potency الهالدول مثلا 3 pluses والباقيين كلهم 2 and then 3 again. يعني there is high likelihood للفيرست generation إنه to cause high prolactin level. The second generations, if there is anyone in particular from the second generation to cause hyperprolactinemia, or they're okay?
Risperidone.
Excellent.
Amisulpride
as well, yes.
Sulpride,
amisulpride, risperidone, risperidone equal to haldol, like similar to first generation antipsychotic, will increase the prolactin level significantly. So when we say risperidone, what other drugs that should logically come to your mind in terms of side effects increasing prolactin level?
Valproic.
Why is that?
Active metabolite of risperidone.
Excellent. Yeah. So that makes sense, right? Okay. While we have some من second generation antipsychotics, زي Abilify, aripiprazole, because it's partial agonist, they don't use hyperprolactinemia, and in fact sometimes we use a small dose of aripiprazole to treat hyperprolactinemia. And that should be your approach if you have someone with risperidone, for example, developed hyperprolactinemia. If the patient is only responding to risperidone, you try to switch to another medication to avoid hyperprolactinemia. And the psychosis, then you have no other way. You need to use the risperidone, but you need to add something else, especially if it's aripiprazole. Those might be a good option to go for. معلش أنا فوت الساعة لكن I'm done here. طبعا ما للأسف حاولت just to touch on the second generation antipsychotics, especially في التيبل ده هنا. لكن there is no time to go over antidepressant and mood stabilizers and other medications. And shukran jazilan. We'll leave it here if there is any question. Like, as I said, I'm more than happy to continue this maybe in the future.
Thank you very much, Dr. Bushra. If anybody has any questions, تفضل.
شكرا دكتور بشرى، شاكرين جدا جدا، وشكرا برضو لأبنائنا المتدربين والمتدربات على الانتراكشن. And this is a sort of ideal interaction session اللي احنا عايزينه. شايف يا ياسر عاصم رافع يده قبل شوية، وفي أسئلة في الشات ممكن تقراها لي يا ياسر. شكرا.
اوكي just a second هنا، انت عارف ثواني. اوكي، في هنا great lecture، في comments هنا دقيقة بس عشان افتكر في كمية من الحاجات جت في نفس الوقت. Can we get a copy of up to date table؟ تاني حاجة is everybody is giving thank you for the presentation. ما شاف في سؤال.
Okay. Yeah, of course, I can send you Yasser the presentation. Yeah. Or if you want me to send a separate table, في other tables as well من up to date the second generation, I can send it to you.
Okay. أنا داير أوقف الشير بتاع السلايد.
I think I need to stop from my side. Stop share.
I have question.
تفضل.
شكرا جزيلا يا دكتور بشرى على المحاضرة القيمة، استفدنا منها كثير جدا ما شاء الله، وربنا يديم العطاء إن شاء الله. بسأل من إذا في هايبر برولاكتينيميا من الأنتي سايكوتيك can be treated by anti-dopaminergic or switch the antipsychotic to other medication or other option of treatment?
Yeah, the first step بالنسبة لنا طبعا في يعني عشان كده this is the importance of having a baseline prolactin level. إنك بتقدر to differentiate إذا كان يعني في underlying physical problem ولا this is only related to the antipsychotic that you're using. A normal prolactin تقريبا من 0 to 20 nanogram. الانتيسايكوتيك ممكن ترفعه لحد 100 nanogram. Risperidone in particular up to 200. في الماكرو أدينوما ممكن يكون thousands. Pregnancy, especially during the last trimester, والpeak بيكون مع delivery ممكن يكون up to 600. We don't know why مع pregnancy، لكن the most common theory إنه the estradiol level بيكون high. عشان كده after delivery within the first 6 weeks estradiol will go low, then the prolactin level will go back to its normal physiologically. مع medications, the first thing إنه try to change the medication لواحد with less likelihood or propensity to cause hyperprolactinemia. Quetiapine, clozapine، لكن طبعا عارفين لازم يكون في other indication for that، لكن they're less likely to cause hyperprolactinemia. To some degree olanzapine as well. Just you need to avoid the sulpride, amisulpride, risperidone, paliperidone, as you suggested earlier. ده بيكون ده المين يعني المين to deal with. لكن using that might يعني need intervention, multidisciplinary team intervention to involve an endocrinologist. But by إنك to stop. And when you stop the antipsychotic medication that was causing the hyperprolactinemia, you suspect the level to go back to normal within 2 to 4 days. يعني ما فترة طويلة. يعني within a week البرولاكتين المفروض يكون خلاص back إذا كان ده caused by an antipsychotic. Otherwise, I would say just involving an endocrinologist because that might be another reason to blame rather than the antipsychotic.
عندك follow-up question هنا من أحمد شريف. If the serum level is high for prolactin, but the patient is asymptomatic, what is the next step of action?
Just especially if the medication used was the perfect medication for him, in resolving the psychosis, I would say just observing the patient, continuous monitoring, measuring the level, make sure that it will not increase more, and that's it. But when they start to become symptomatic, that's when you need to treat. And hyperprolactinemia, think about the other possibilities. So you have to ask, لأنه أحيانا patients will not share all of their complaints about the medication, especially like sexual side effects. So a lot of sexual dysfunction comes with hyperprolactinemia. In younger age, less than 22 or older age, hyperprolactinemia can affect, especially in elderly with osteoporosis, can lead to pathological fractures. So it's not good, even if it's asymptomatic, for someone who is with a history of osteopenia or a history of pathological fractures, even if they don't complain of anything. But once you know that risk, it might warrant switching to another thing. In younger population, because of the bone metaphysis and metaphyseal closure, it takes up to the age of 22, 24. So you wanted to avoid this medication that can increase prolactin level in this population, even if there is no symptoms.
في عاصم رافع يده and his turn لكن بس في سؤال في الchat is on the same line في previous conversation. The choice of bromocriptine as an option. ولا مثلا cabergoline as an option, dopamine agonist for the treatment of hyperprolactinemia.
Yeah, again هي طبعا دي used لكن احنا we usually involve في انه المين concern ما هو في النهايه لو ما في other because يعني idiopathic hyperprolactinemia it's one of the differential. احيانا ما بكون عندك اي reason, not the antipsychotic or no other physical problem can be detected, then you will go with these medications. But just the concern is not to miss an underlying physical problem. And of course, you can't control your medication because if you stop your antipsychotic, you should expect a lower prolactin level. But yes, this class of medication, bromocriptine, commonly used to treat hyperprolactinemia.
افتكر هي الكونسيرن هنا بس مثلا is there a risk للميديكيشن like bromocriptine هنا for making psychosis worse?
ما هو احيانا الريسك زي يعني there are certain situations حتى ممكن يكونوا more risky, يعني مثلا ال patients with Parkinson's disease who develop psychosis. So that's a very challenging situation where when you treat so when you treat the Parkinson, there is more likely of worsening of psychosis. And when you treat psychosis, there is worsening of Parkinson's disease. But there is some evidence for certain medication to treat these people. And the evidence is for clozapine, again, which is not indicated for everyone. But more commonly used in these situations is quetiapine. So I would say the same. The quetiapine would be the best option, unless you have an indication to use clozapine.
نرجع لعاصم هنا. عاصم تفضل.
السلام عليكم. شكرا دكتور بشرى. صوت مسموع يا محمد؟
واضح.
ايوه. بس سؤالي انا في لو البيشن عندنا بيشن كان ويل كنترول, هو كيس اوف كرونيك شيزوفرينيا ويل كنترول دور ريسبيريدال كوليستا, دي بوت ريجولر يعني منصلي كان بياخذ الريسبيريدال كوليستا. unfortunately عنده هايبرلاكتين. when we shifted him to Amplify Mentena, symptom return again, but prolactin drop down. What we can do in this situation?
Yeah, the perfect example on what we said earlier. Sometimes الميديكيشن دي ما كلها بتشتغل لنفس الناس، وده كله عشان الحاجات اللي ذكرناها قبل كده، الميتابوليزم والليفر فانكشن الكدني فانكشنز بروتين ليفل اند سو فورث. فاحيانا بتلاقي واحد انه responding very well to risperidone، غيرت لحاجه ثانيه psychosis رجع ثاني. You have to go back into your it's kind of balance يعني risk versus side effects. So you need to go back to risperidone, but you need to use Abilify not as an aripiprazole, sorry, I shouldn't be using trade names, not as an antipsychotic, لكن as a treatment. عشان كده الاريبيبرازول يعني في بعض الريفرنسز بتلقاه انه known as prolactin sparing antipsychotic. Similarly spironolactone مثلا في مع diuretics اللي هو potassium sparing diuretic. Aripiprazole is prolactin sparing antipsychotic because it's partial agonist. You need to use that small amount, 2, 5 milligrams, 7.5, however less than the 10, which is the lowest antipsychotic dose to treat hyperprolactinemia, while you're maintaining your primary antipsychotic medication, which is the risperidone in this case.
Right. عندنا سؤالين في الشات، ودي آخر سؤالين، ما هناخذ أسئلة ثانية بس عشان نحفظ الزمن. السؤال الأول من إيمان: In the management of akathisia induced by injectable long-acting Abilify, would the management be the same as for oral induced one?
Yeah, just you need to be more careful, as I said, because you don't want to introduce. It depends on the washout period. So when was the long-acting medication given? If it was weeks, it's about to end, then you might try another medication with lower propensity to cause akathisia as a first step. But if it was just taken 2 days ago, so you need to allow for a washout period. Maybe it's so early to start another antipsychotic now, especially if the patient with you in the inpatient setting, you will be able to monitor them, and you need to start a different medication to treat the akathisia. And as we said, you have different options. Again, it's an individualized approach, whether mirtazapine, propranolol, benzos, vitamin B6, but you have all of these options.
السؤال الأخير, which is an interesting question from Hala Taha. How crucial is the genetic testing you mentioned earlier on for drug metabolism? Do you find it makes significant difference among patient outcome?
Yes and no. Yes, لأنه especially with it's an expensive test if it's not covered. لكن we use it بالذات مع let's say treatment resistant cases مع antidepressant. Use SSRIs, SNRIs, TCAs, augmenting strategies, no benefits. Patient is refusing ECT, TMS for whatever reason, and you just stuck with that. So you need a genetic study in that case, because I found this in one of my patients actually, and they were البروبلم كانت ما مع non response to medication. التست ده ما بوريك which medication you should use. يعني ما بوريك patient this patient is likely going to respond to Cipralex مثلا. No. لكن بوريك العكس. This patient might not benefit from Cipralex, should be avoided. So you have the option to go for other patients. الحاجة الثانية بوريك for other options. الحاجة الثانية بوريك probability of developing side effects. يعني ممكن يكونوا هم slow metabolizers, so you need to use the same medication لكن in a much lower dose, and instead of starting Cipralex 5 milligram or 10 milligram, you have to start 2.5. وزمان لما كنت بتبدا 5 البيشنت develop side effects بيوقفوا، انت تمشي لواحد ثاني. So you have to go back and start it lower.
شكرا جزيلا دكتور بشرى. قبال ما ادي الميكروفون للدكتور عبد الغني، اذا عايز يضيف حاجه، في حاجه اضفناها المره دي في المحاضره دي از التجربه، ولسه عايزين نحسن في الاداء ونحسن نشوف مثلا الفيدباك بتاع الناس. عملنا حاجه اللي هي بوست ليكتشر سيرفي، ده عشان مثلا تورينا مثلا شنو وات يعني هنا، اذا في حاجه المفروض تتعدل، حاجه تتصلح، مثلا حاجه انتم عايزينها لقدام، what was worked well what did not work well. الحاجه دي احنا دي اول مره نشوفها، فدي حاجه فيدباك لنا احنا، فيدباك ذاته للمحاضر، حاجه ممكن نحصلها، لانه الموضوع ده احنا عايزين نقدمه لقدام، نخليه احسن واحسن واحسن للفتره الجايه. فانا ممكن اشير السيرفي. اول حاجه احنا لسه we're trying this، ما عارفين الموضوع ده ماشي كيف، اي في البلاتفورم اللي احنا شغالين به ده حينفع ولا هنشوف لنا حاجه احسن، لكن I'm sharing this في الشات. وانا ادي الميكروفون للدكتور عبد الغني.
شكرا جزيلا، شكرا دكتور بشرى. This was very interesting and